Okay, so we will discuss about the aldosteronism. Okay, hyperaldosteronism. So here the aldosterone will be increased from the adrenaline system, adrenal gland. Okay, so what happens? So hyperaldosteronism can be defined as excessive level of the aldosterone, which may be independent of the renin-angiotensin axis, primary hyperaldosteronism, or drug due to high renin level. It's called the secondary aldosteronism. Okay, so there are two types of the hyperaldosterone. There is the renin independent of the renin-angiotensin axis. That's the primary hyperaldosteronism, and secondary is the due to high renin level. That's called the secondary hyperaldosteronism. Okay, now what is the pathophysiology? So excessive aldosterone level act at the distal renal tubule. Okay, excessive aldosterone will act on the distal renal tubule. Okay, distal renal tubule, as we seen earlier, that this is the proximal, then this is the uh, loop of Henle, this is the distal tubules. Okay, so the aldosterone will act on the distal renal tubule, promoting sodium retention, which results in the water retention and volume expansion with the hypertension. Okay, there is also excretion of the potassium results in the hypokalemia. Okay, so from here the uh, sodium and water will be reabsorbed and the potassium will be excreted. Okay, so there will be the hypokalemia in the body, and uh, due to the volume expansion it will cause the hypertension. Now so in the limited level of the aldosterone, this is the beneficiary, but when the aldosterone is very high, that's the hyperaldosteronism. This causes the sodium and water retention. Excessive sodium and water retention will cause the hypertension, and excessive potassium loss will also cause the hypokalemia. Okay, now what are the causes of the primary hyperaldosteronism? So in the primary hyperaldosteronism, it is not dependent on the renin. So how primary hyperaldosteronism will occur? So it due to adrenal adenoma, that's the Crohn's syndrome, account for greater than 80% of cases of the primary hyperaldosteronism. Then adrenal hyperplasia, then familial hyperaldosteronism, and adrenal carcinoma. Okay, due to the adrenal disease like the adenoma, then hyperplasia and the carcinoma, all of the adrenal disease, and last is the familial. It will cause the primary. Then features of the primary hyperaldosteronism. So hypertension, hypokalemia, metabolic alkalosis, hypernatremia, maybe high and of normal or only mildly raised. Then aldosterone level is high and renin level low. What are the features? So hypertension, as we have seen just now, then the hypokalemia also we have seen, then metabolic alkalosis. Okay, metabolic alkalosis, then the hypernatremia. Okay, we also have seen that hypernatremia may be high end of normal or only mildly raised. Then aldosterone level will be also high, and renin level will be low. Okay, due to the negative feedback, and the renin will be low, and the aldosterone, due to positive feedback, the aldosterone will be high. Okay, then what is the management of the primary hyperaldosteronism? So in the management, medical management is used in the period prior to surgery. uh, okay, so we have to first do the medical management, which is the defined definitive treatment. Medical management involves the use of aldosterone antagonist. Okay, uh, we have to use the aldosterone antagonist. There is the spironolactone. Surgical treatment involves the adrenalectomy. Okay, so we have to give the spironolactone, and the it is the medical management, and the surgical management is the adrenalectomy.